Good morning, all. Thanks to the ISCCM team Hyderabad. Today's my topic is acute meningitis and encephalitis in intensive care unit. My topic runs in the following subheadings: definition, presentation and clinical features, early management and evaluation, epidemiology, investigations, treatment, complications, long-term sequelae, care and prognosis. We all know meninges is the covering layers of the brain, and the space between the layers is getting infected. So we call it as a meningitis, and this infection is extending into the cerebral parenchyma. We call it as encephalitis. So the definition wise, meningitis is an inflammation of the meninges, which covers the brain. Encephalitis is the inflammation of the brain parenchyma. It's definitely a neurological emergency, and it's caused by infection. Clinically, it's very difficult to distinguish between the viral meningitis and bacterial meningitis. So we often call this as a meningoencephalitis. So next thing is the treatment plan is as early as possible should be planned. As per the requirements, it should be covering both viral and bacterial meningitis. Coming to the next, the important finding is as early as possible, we need to do a CSF analysis to identify the organisms. Then maybe there is the onset, maybe it's a slow ongoing onset or a sudden fulminant onset also described in this meningitis. Basically, the meningitis contains a triad of things like a fever, altered sensorium, and seizures is the one thing. And some people may be presenting with a headache. So when patient is having these three things, we have to have a strong suspicion of meningitis. And diagnosis should be aimed to as early as possible. We need to conduct an LP and identifying the organism either by cultures or by the analysis which supports the bacterial meningitis versus viral meningitis. And next possibility is like the symptoms like meningism is more towards a bacterial meningitis. And the thing is, we need to identify a bacterial pathogen in the blood. So blood cultures need to be sent along with the CSF analysis. And we also there is a possibility of finding the organism by a PCR test in the CSF. Rapid diagnosis and treatment is very, very important. Otherwise, this patient, there is every tendency to go into long-term neurological sequelae. The meningitis versus encephalitis, as I have discussed about, the inflammation of the layers is meningitis, the inflammation of the brain parenchyma is encephalitis. The presence and absence of normal brainstem functions, like normal brain functions, is particularly if it is present, it is possibly it is an encephalitis. It is absent, it is more towards meningitis. But it is not a clear-cut delineation or demarcation. But grossly speaking, meningitis will have less CNS symptoms, whereas encephalitis patient presents with seizures, altered mentation, sensory and motor neurological deficits, behavioral changes, personality changes are expected in encephalitis patients. Seizures and post-ictal state can also be presented in the meningitis, but there is no specific thing that it is the only thing that is the differentiating factor between the meningitis to encephalitis. Hemiparesis, flaccid paralysis, paresthesia all are described in this as the manifestations of the CNS infections. Next comes the distinction between this meningitis to the encephalitis. There is a very subtle line which can demarcate between these things. So we need to start antibiotics covering both meningitis and encephalitis as early as possible. Coming to the epidemiology and what is the commonest organism, like bacterial and viral are the commonest organisms, and the rarest possibilities are TB meningitis because of the TB vaccination does, and fungal meningitis is only in immunocompromised patients. There is an entity called as Aceptic Meningitis where we are not able to find out any organism despite the patient is symptomatically supposed to have meningitis and encephalitis. And one more rarest possibility is drug-induced meningitis because of the adverse drug reaction. Coming to the bacterial meningitis, the commonest pathogens are three pathogens are identified: streptococcal pneumonia, Neisseria meningitis, Haemophilus influenza type B. And the South Asian countries, the commonest bug is Streptococcus suis, and elderly people, it is Listeria monocytogenes, and group B streptococci. And gram-negative bacilli also contribute. The commonest organisms are E. coli and Klebsiella. These are all related to the community-acquired bacterial meningitis. Risk factors to have a listeria suspicion is any patient who is a relatively immunocompromised patient, as a chronic illness is a background of history and comorbidities, and diabetes, alcohol dependency, malignancy, and old age people, we need to suspect listeria meningitis. Viral infections, herpes simplex is the commonest, and next comes the varicella zoster, and other bacterial infections could be Mycobacterium tuberculosis, where the children from the poor socioeconomic status, we need to suspect it's a TB meningitis. And coming to the nosocomial meningitis, in hospital acquired meningitis, mostly it is MRSA and gram-negative multi-drug resistant bugs. Then post-operative or post-traumatic patients, post-neurosurgery, post-CNS trauma, and post-indwelling VP shunt or something like, we need to consider methicillin resistant staph aureus and Enterobacteriaceae group, Pseudomonas and Acinetobacter. Some maybe the parasitic infections also causes this meningitis like Toxoplasma gondii, and maybe this is an amoebic meningitis also described. Coming to the continuation of the viral encephalitis, encephalitis is the most common. Enterovirus like Coxsackie and echoviruses are common, and 80% of the all patients with the aseptic meningitis, the possibility is viral meningitis. Herpes simplex causes 90% of the viral meningitis, and which is having a high mortality and morbidity if it's not identified in the early phases and not able to treat that. And less common causes are HIV, cytomegalovirus, mumps, and varicella zoster. Infections with cytomegalovirus, Epstein-Barr virus, and human herpes 6 virus is most commonly seen in immunocompromised patients. The other entity is fungal meningitis, is secondary to systemic mycosis. The commonest is Cryptococcus species in an immunocompromised patient. Coccidiosis and histoplasma are less common, and candidal infection is an extension to the patient who is already having a invasive candidiosis, and it's a mostly of a hospital-acquired infection. Aseptic meningitis, as definition, like we have a clinical and laboratory evidence of meningitis, but we are not able to find out the bug in the blood cultures or CSF cultures. The most common is enterovirus, and the other possibilities are Mycobacterium, parameningeal infections, medications, spirochetal infections, and fungal infections. Malignancies also can cause aseptic meningitis, and it is a self-limiting course, and usually it doesn't have any mortality, and the recovery is almost expected. Drug-induced meningitis is the rarest entity, and it is due to because of the usual adverse reactions of the drugs. And the commonest drugs are NSAIDs, and antibiotic group is trimethoprim sulfamethoxazole, intravenous immunoglobulins, rifacoxib, cetuximab, anti-epileptic drugs, and other medications. This is the rarest condition. The two mechanisms are observed here is one is delayed hypersensitive type reaction and a direct meningeal irritation. The CSF profile typically is a neutrophilic pleocytosis. Symptoms often resolve by itself. There is no specific like morbidity and mortality in the patient who is having a drug-induced meningitis. How the patients are being presented in a meningitis or meningoencephalitis patients. The syndrome of meningoencephalitis ranges from simple meningeal inflammation to inflammation of the brain parenchyma. If it is a meningeal inflammation, patient will present as headache, fever, and nuchal rigidity. If this infection is extended onto the brain parenchyma, we may have symptoms related to cortical dysfunction. Symptoms of seizures and focal deficit can also be present, and patient may have hemiplegia, aphasia. The classical triad of fever, stiffness, and altered sensorium we see only in the patient group of less than 50%, and 95% will present only 2 out of the 3 symptoms. Like they may have a combination of fever and neck stiffness, may not have an altered sensorium. Likewise, any 2 of these 3 symptoms can be having in 95% of the patients. Multiple cerebral infarcts secondary to the vasculitis and cortical venous thrombosis also expected, and further leading to complications leading to cerebral edema. Raised ICP need to be kept in mind. And patients who are presenting with these 3 symptoms having a rash, most probably we can think of it is a meningococcal infection in 90% of the patients. So independently, neck stiffness we find in 31%, Kernig sign we found in 9% of the people, Bergensky sign 11% of the people, and definitely because it is very, very small number, we don't have a diagnostic accuracy looking at these symptoms or signs. Ataxia and labyrinthitis, if they are present, we have to, like, there is a possibility we have to include H. influenza meningitis is a possibility. Patient presenting with a cough, weight loss, and cranial nerve deficit, think of TB meningitis. And patient who is having a septic shock, pneumonia, then consider it is like secondary complicated bacterial meningitis. So coming to the nodular rigidity, we have two different signs, Brzezinski sign and Kernig sign. Kernig sign is the resistant to extension of the leg while the hip is flexed. So this is one thing. So if I have flexed my hip and I'm trying to extend my knee joint, then there will be resistance to the extension. In a Brzezinski sign, flexion of the hip and knees, there is a response to the neck flexion. I'm trying to flex the neck in a lying down patient. There is a flexion at the hip and flexion at the knee joint. These two signs suggest that there is a meningeal irritation. In viral meningitis, prodromal symptoms will be there, fever, myalgia, headache, and respiratory infection. Altered mental status, focal neurologic deficits are common in viral infection because it is a viral encephalitis. Herpetic rash in the herpes simplex encephalitis. Brainstem involvement leads to the diplopia, dysarthria, bulbar palsy. These things also to be considered. And personality changes and memory loss is expected when the site of infection is like localized to temporal or orbitofrontal areas, particularly in the herpes simplex encephalitis. So diagnostic criteria, looking what the evidence is, what is the diagnostic accuracy of algorithmic approach, the distinction between the bacterial to viral meningitis. Do we have any algorithm? Should we follow this algorithm to delineate depending upon the symptoms and presentation, whether it is a viral or a bacterial? So for this, there is nothing so far established diagnostic algorithm which has 100% sensitivity. So it is a level 2 evidence. And next comes that usual diagnostic algorithms will delineate and guide us in the management of individual patient with suspected bacterial meningitis. But clinical judgment is a key when considering whether it's start empirical antibiotic and adjuvant therapy. This is a level C evidence. So as of now, evidence-wise, there is no published data or evidence that can delineate by following an algorithmic approach to differentiate between a bacterial meningitis and viral meningitis. Coming to these specific points, like how do we diagnose? So we have a symptoms. Now the thing is, we need to send all the basic investigations like complete blood picture, lipid liver function test, renal function test, coagulation profile. Then the basic thing we need to look for a lumbar puncture and CSF to be sent for analysis. What are the things we are going to look in the CSF? First of all, look into the opening pressures, send for TLC and a differential count, sugar, protein, gram stain and cultures, lactate in the CSF, PCR assay, which is a rapid diagnostic test, and adenosine deaminase for Mycobacterium tuberculosis, and RT-PCR for TB, and nucleic acid enhancement test for TB. These things are required. So these are the battery of things that need to be looked into the CSF analysis. Coming to the leukocyte count in the CSF, we can have an arbitrary support that looking at this in the cells, obviously this meningitis cell count should be more than 5 per a microliter. And if the leukocyte count is more than 1000, particularly neutrophilic predominant, it's more towards bacterial meningitis, but the exceptions are Listeria monocytogenes. Here the cell count can be less than 1000, but it is also lymphocytic predominant. In viral meningitis, cell count is less than 1000 and lymphocytic predominance. So also in the tuberculous meningitis. A traumatic tap, very, very important thing is if it is a traumatic tap, the leukocyte count should be corrected by deducting the leukocytes for every 500 to 1000 RBC in the CSF. Then coming to the protein is usually elevated in infections. due to increased permeability at the blood-brain barrier, the consequence of the inflammatory process. The elevation is greater than 1, it is TB meningitis, and it is less than 1, it is viral meningitis. Exceptions: meningitis due to herpes simplex, there is a possibility protein content may be more than 1 gram per liter. Similarly, as we discussed in the leukocyte count, here the CSF protein also, if it is a traumatic tap, deduct 0.01 grams per liter for every 100 red blood cells. Coming to the glucose in the CSF, hypoglycoregia. So sugars are low in the bacterial meningitis, also seen in the TB meningitis and cryptococcal meningitis. Normal CSF to blood glucose ratio is 0.6. So this normal ratio is usually maintained in viral meningitis. If the ratio is less than 0.5, it is highly sensitive for a bacterial meningitis, but specificity is only 57%. If the ratio is less than 0.0323, the specificity improves to 99%, but at the cost of sensitivity. So next comes the CSF to blood glucose ratio may be less harmful, less helpful in hyperglycemic patients. So these things are the setbacks looking at the glucose content of the CSF. Coming to the overall picture and delineation of the viral, bacterial, tuberculous, fungus depending upon the CSF analysis. CSF WBC count is more in bacterial meningitis, relatively less in viral meningitis. Significant, predominantly lymphocytes in the viral, predominantly leukocytes in the bacterial meningitis. CSF protein is much raised in bacterial and TB meningitis. Viral meningitis is mildly raised. And CSF glucose is significantly decreased in bacterial meningitis, normal in viral meningitis, very low in tuberculous meningitis. The contraindications for LP. So as you understood that LP is has a pivotal role in diagnosing the meningitis, but at the same time, all patients, just like that, we cannot do LP. Before doing LP, we need to consider two things. Is the patient is having a raised ICP? Is the patient is having a coagulation abnormality? So any patient we found to have a raised ICP, clinically we need to look for a focal neurological deficit, any seizures at the presentation, and particularly in the patient GCS is very low, and past history of immunosuppression medications or immunosuppressive diseases. These patients require a CT before doing an LP, then only we can conduct an LP procedure in this patient. Similarly, the patient coagulation profile, platelet count is less than 50,000, INR is more than 1.8, and APTT is more than 2 times. So this is the contraindications to go for a lumbar puncture to have a CSF analysis. So clinical predictions of the raised ICP. Can we use clinical characteristics to predict the absence of intracranial abnormalities associated with increased risk of lumbar puncture? Any patient who is having a focal neurological deficit like cranial nerve palsies and a new onset of seizures, severely altered mental status, GCS is less than 10 to 8, and patient is immunocompromised state, these patients clinically there is high and strong suspicion to have a raised ICP. Coming to the evidence, CSF lactate is definitely more towards bacterial meningitis, and if it is low and very less, we need to consider it could be aseptic meningitis. CSF culture positivity 60 to 90% of bacterial meningitis. And coming to the CSF gram stain, high specificity and varying sensitivity. Next is a negative CSF culture and CSF gram stain. There is a possibility we need to consider like PCR, rapid PCR test will add to the diagnosis, and latest agglutination test and other immunochromatographic tests are less reliable in these conditions. All the 5 points are only level 2 evidence. Then coming to the grade 1, very strong evidences like, so it's a strongly recommended is CSF analysis, looking into the leukocyte count, looking into the protein, looking into the glucose concentration, cultures and gram stain is very important. It's a strong evidence. Then another evidence is PCR based test, which gives early recognition, because cultures will take 2 to 3 days, but we can go with the amplification PCR test. We can identify the bug within 4 to 6 hours. Then another strong recommendation is blood cultures should be sent before the administration of antibiotics. As early as possible, I have to better to give antibiotic. So that is very, very important. So these three are grade 1 evidences. Then coming to the CT before LP, it's strongly recommended in patients who are having a focal deficit, new onset of seizure, severely altered mental status. And if the patient is not having these symptoms, there is no recommendation to go for a CT before trying an LP. So next is, if lumbar puncture is delayed, should we start treatment? Yes, this is to be done, because don't wait for the LP to be done. If we have a suspicion, start antibiotic as early as possible. It's a strong recommendation, grade 1 recommendation. And in bacterial meningitis particularly, lumbar puncture is delayed due to CT and blood cultures to be sent, empirical treatment, antibiotics should be started. Don't delay the antibiotic treatment just for the sake of doing a CT or just for the sake of obtaining an LP sample. So coming to the differential diagnosis at this point, all tropical infections, any patient who is having a febrile encephalopathy, the conditions which we come across, cerebral malaria, dengue encephalopathy, leptospirosis, scrub typhus, we need to send all the required investigations to rule out these diseases. And patient is having a septic encephalopathy, patient may have a metabolic encephalopathy, hyponatremia, hepatic encephalopathy, uremic, dysglycemic encephalopathy. So all these things comes under the category and the list of differential diagnosis, and all the relevant investigations need to be sent to rule out these possibilities. And coming to the specific treatments, we normally come across a patient between around 50 years, or we don't treat neonatal patients or pediatric patients, where our concern is adult and geriatric patients. So adult patients, the commonest thing is Neisseria meningitis and streptococcal pneumonia. The treatment of choice is vancomycin plus a third generation cephalosporin. And patient who is having more than 50 years, the suspected bug could be all the Neisseria meningitis, strep pneumonia, also need to be considered empirically to cover Listeria monocytogenes and aerobic gram-lactobacillus. So as per the previous recommendation, like vanc plus third generation cephalosporin, also there is addition of ampicillin to cover Listeria. Medications, what is the advantage of adding vanc with rifamycin? Does the addition of vanc or rifamycin to third generation cephalosporin improves the outcome in pneumococcal meningitis patient in setting of high resistance rate of pneumococci? Yes, it's a combination with vanc and ceftriaxone or cef is definitely resulted in high rate of CSF sterilization after 24 hours compared to the monotherapy, but it does not have any significance or any improvement in the mortality. But the duration of antibiotic should be given up to 14 days. This is when the patient cultures are back and we identified the bug. Yes, there is a culture, bug specific antibiotics need to be instituted, and the duration of treatment is up to 14 days. What is the optimal time, duration, and method of administration of antibiotic treatment when started empirically after the pathogen has been identified culture? That we have discussed. Evidence-wise, all are grade 1 evidences. First is, based on the age, we need to give an empirical antibiotic, cover the Listeria if the patient is more than 50 years. And second thing is, susceptibility pattern come back and we need to target the bacteria depending upon the susceptibility. Third one is, if there is no pathogen is cultured in the CSF, the empirical antibiotic regimen should be continued for minimum of 14 days. And next is grade 4 evidence, not recommended short course of antibiotics. So always give an antibiotic course up to 14 days. Because of lack of evidence, the committee does not provide a recommendation use of continuous or bolus administration of the antibiotics. The recommendation is, for the viral, no standard approach or the treatment of viral infections, but if is an HSV virus suspected, start intravenous acyclovir at 10 milligrams per kg body weight, administered every 8th hourly, and dose need to be adjusted in the patient renal parameters are altered because it's a nephrotoxic and worsening the renal parameters, and the dosage should be given for 10 to 14 days. And the advantage is we can switch over to oral acyclovir once the patient clinically seems to be better. Then coming to the important aspect is adjuvant therapies. So role of steroids in treatment of meningitis. Particularly steroids abort the effect of inflammatory cytokines that are released due to the bacterial lysis by our antibiotics. So these inflammatory cytokines are responsible for most of the complications like seizures, sensory neuronal deficit, hearing loss, venous infarcts, and raised ICP. Treatment with steroids seems to be lower the incidence of the complications, particularly in the streptococcal pneumonia, and there is a specific survival benefit. Current guidelines recommend dexamethasone 10 milligrams IV 6th hourly, and along with the antibiotic or just prior to the antibiotic is recommended. And if it is a pneumococcal meningitis, the duration of steroid should be for 4 days. Steroids also a part of the standard therapy in TB meningitis, but the dose and duration of the treatment differs. And definitely it showed a decrease in the mortality. The dose is 0.4 milligrams per kg body weight IV in adults and should be continued for 4 days. With it, after it should be tapered over a 2 to 4 weeks period. In viral encephalitis, early there is a strong negative recommendation: don't use steroids within 4 days. But use of steroids after the 4th day reduce the complications, thereby improving the outcome substantially. When to start steroids? Up to what point in time the treatment with the dexamethasone indicates if antibiotics are already started? Yeah, if antibiotic is already started, we can start steroids within 4 hours of the start of the antibiotic. That is a level 3 evidence. Then dexamethasone, a beneficial effect on the death, functional outcome, and hearing loss in the adult. In the children with bacterial meningitis, yes, definitely. Corticosteroids significantly reduced the hearing loss and neurological sequelae, but did not have a reduction in the overall mortality. The recommendations, grade A, what we discussed is empirical treatment with the dexamethasone, particularly in the bacterial meningitis. The bug, if it is suspected more towards pneumococcal meningitis, then treatment with the dexamethasone strongly recommended along with the first dose of antibiotic. Grade C evidence is within 4 hours of the start of the antibiotic. Grade B evidence is stop dexamethasone if the meningitis is not of streptococcal pneumonia. So the thing is, if it is more useful in H influenza and streptococcal pneumonia. Rest of the bacteria, it may not have a significant advantage. Coming to the complications, seizures, hydrocephalus, ischemic stroke, hemorrhagic stroke, subdural lymphoma, brain abscess, venous sinus thrombosis, severe sepsis, hearing loss, hyponatremia in the form of cerebral salt wasting acid. These are all the list of complications where you can expect a patient having a meningitis. Coming to the evidence, neurological systemic complications occur in large proportion of the children and adults with bacterial meningitis. So we need to have a serial evaluations of the CNS like MRI, CT brain, and often we require repeat lumbar punctures and EEGs to find out the non-convulsive status epilepticus. Then level 3 evidence is bacterial meningitis complication can be like hydrocephalus, subdural lymphoma, and brain abscess may require a neurosurgical intervention. The recommendation is perform ancillary investigations as frequently as possible to early identification of the above said complications. The first complication, think of acute hydrocephalus, most common in tuberculosis and cryptococcal meningitis. So next is hyponatremia due to either cerebral salt wasting or inappropriate antidiuretic, syndrome of inappropriate antidiuretic hormone may lead to the altered sensorium. Seizures may occur in 15% of the cases in acute meningitis. So we need to go with a EEG analysis, particularly to rule out a non-convulsive status epilepticus. Sensory neural hearing loss with a bacterial meningitis is suspected. Acute stroke due to vasculitis, cerebral venous thrombosis, cerebral edema. There is a possibility of raised ICP in these conditions. Then all these patients require anti-edema measures, including osmotic diuretics, but does not show any significant benefit. But we need to treat the complication. So we need to include anti-edema measures and particularly osmotic diuretics. Next thing is, do glycerol, mannitol, acetaminophen, paracetamol, hypothermia, anti-epileptic drugs, hypertonic saline have a beneficial effect on the death, functional outcome, and hearing loss in adult and children with bacterial meningitis? It's a grade D evidence, does not support to have a mannitol, acetaminophen, anti-epileptic drugs. Hypotension is no recommended and does not have any positive outcome. Hypothermia and oral glycerol also contraindicated in bacterial meningitis unless there is a sequelae of the raised ICP. Grade C. Does this patient have a benefit by doing an ICP monitoring? Yes, definitely it is not useful. It's not a routine recommendation to have a ICP monitoring for all patients, but it is useful in the management, like use of intracranial pressure, cerebral pressure monitoring, and treatment can be life-saving. Selected patients only, not for a routine practice. Then adjuvant therapy with immunoglobulins, heparin, and activated protein C, not recommended. Prognosis-wise, mortality is very high in meningitis patients, almost exclusively in bacterial meningitis, up to 57% meningococcal sepsis, 30% pneumococcal, 7% in meningococcal meningitis without sepsis. So morbidity is very common in the bacterial meningitis. As per one study by Van de Beek's study, focal neurological deficit is in 50% of the cases, the commonest being hearing impairment, and 14% of the cases exhibited moderate to severe disability at discharge. So highly devastating disease, high mortality, high morbidity. The take-home message: meningitis, meningoencephalitis, encephalitis, all these three entities are neurological emergencies. Clinically, it is very difficult to distinguish between a viral and bacterial meningitis. Less than 50% show classical triad of fever, stiffness, and stiff neck and altered sensorium, but 95% of the patients showed 2 out of these 3 symptoms. Symptoms confirmed is immediately LP should be done to identify and delineate the whether it is bacterial or viral meningitis. CT prior to LP in conditions where there is a suspected raised ICP. Early broad spectrum antibiotics along with antivirals to cover HSV is recommended. Steroids along with first dose of antibiotic or within 4 hours of the antibiotic is recommended as an adjuvant therapy. Close monitoring to identify the complications and treat the complications, because it has a high mortality and high morbidity if the patient lands up into complications. Thank you. Thanks for the opportunity. That's all. This is now open for questions.